and welcome to Conversations with Dr. Kohli. I'm your host, Dr. Payal Kohli. I'm an associate adjunct professor in the cardiology division at Duke University, non-invasive and preventive cardiologist, and founder and medical director of Cherry Creek Heart in Aurora, Colorado. And today, I'm delighted to be joined by my colleague, Dr. Michael Miller, who is cardiologist and professor of medicine at the University of Pennsylvania and the chief of medicine at the VA Medical Center in Philadelphia. Welcome, Mike.
Thank you, Dr. Kohli.
We are in for a real treat today with Dr. Miller because he's really an expert in how to think about triglycerides. In fact, I remember reading his chapters about triglycerides when I was a medical student, first learning about triglycerides at Harvard Medical School. So, Mike, as a trainee, I must have written hundreds of fibrate prescriptions because when I was training in med school and residency, we really thought of fibrates and using them to lower triglycerides the way that we think about LDL cholesterol. We treat the number. We write a prescription for fibrate because it gets that number down and it really gets us feeling better. But today, 2 decades later, this may shock you, more than 50% of primary care physicians and cardiologists still believe that fibrates reduce cardiovascular risk, and there are over 250,000 fibrate prescriptions every single week. So, we think we're doing the right thing, but of course we aren't. And that's what I want to talk to you about today is, how do we think about the use of fibrates in cardiovascular risk reduction? And I want you to sort of take me through a history where we were, where we are today, and really where we ought to be.
Well, Payal, it's pretty astounding that there are so many prescriptions written for fibrates. And I would think that might be the old timers, right? Because when the early trials of fibrates came out that used the fibrate gemfibrozole, the results were actually very remarkable. So there were 2 trials actually that came out during my training and a little bit when I had started out. And the first study was called the Helsinki Heart Study. So it was done in Finland, primary prevention, and in patients that just had high levels of non-HDL cholesterol. I think it was mean was somewhere about 200. And they found pretty significant reductions in the in incident coronary events. So the first event was reduced in about 34% or so. A second study, known as the VA HIT study, because it was done in a veteran population, and it was the so-called HDL intervention trial. While there were triglyceride reductions, there was also a modest HDL increases. And in this secondary prevention trial, there was also a significant reduction in secondary cardiovascular events, somewhere in the low 20s, maybe 22%. Now, the unfortunate part about these 2 trials was that they occurred in the pre-statin era. And so when fibrate was used alone to treat hyperlipidemia, it worked. However, there was an exception along the line of these trials, and that was in the Accord trial, where in patients that had some, and I should point out that these studies, both the Helsinki Heart Study, the VA HIT study, was not specifically done in hypertriglyceridemic patients. So now we are doing subsequent studies, and they're all negative in the statin era. And that's where we kind of diverged from the early studies. Was it just gemfibrozole that was, that was a magical fibrate, as opposed to fenofibrate and some of the other fibrates? But the bottom line is that they did not look at hypertriglyceridemic patients. However, in the Accord study in diabetic population, there seemed to be a combination of simvastatin and fenofibrate in a pre-specified analysis appeared to show a favorable trend. It was 0.06. And so that led to the most recent study known as Prominent, but that also turned out negative. And these were exclusively hypertriglyceridemic patients assigned to pemafibrate plus standard of care versus standard of care only. No difference in the groups.
It was really fascinating when I saw the Prominent data because the deck was really stacked for that study to be positive, if it was going to be positive. And as you know, it was stopped early for futility. This was in hypertriglyceridemic patients with the low HDL, really the ones that would have benefited. So, okay, so we've now sort of established, I think, pretty well that fibrates do not reduce cardiovascular risk and they shouldn't be used for prevention. They treat the number, but not the risk. So tell me, Michael, when should I be using a fibrate in clinical practice, and what are the guidelines around when it does make sense to use a fibrate?
Well, so I mean, if you're a guideline purist, you would say never. There's no indication because the guidelines don't really call now for statins. And the FDA also said, as of we stopped using combination of fibrate and statins starting in 2016 when the FDA came out and said, there's no benefit vis-a-vis cardiovascular disease reduction. So, but there might be two scenarios when a clinician may want to use a fibrate. And that might be in patients with significantly very high triglycerides above 500, with the notion that maybe they'll reduce the risk of pancreatitis, even though there have been no studies, to support that. But some physicians or healthcare practitioners may say, well, your triglycerides in the 800 range, let's not take a chance. Let's try and run a fibrate. We know it's going to reduce triglycerides, 40, 50%. Why not? So that's one indication. The second is one of the features that came out of the prominent study was that pemafibrate tended to be beneficial in patients that had non-alcoholic fatty liver disease. Mm. So there may be a role for fibrates to improve LFTs or reduce fatty liver and reduce fibrosis, progression to fibrosis, as has been suggested. Again, not part of the guidelines, but in our patients whom we believe, because of their elevated triglyceride, may be at risk for those problems.
Okay, so I'm not using them to treat cardiovascular risk. I'm using them to treat the number if it's over 500. If it's under 500, it sounds like I should be thinking about cardiovascular risk reducing medications. So there, I want to switch gears a little bit and talk to you about mixed omega-3s and about over-the-counter fish oils, because these are both, medications that our patients often come in on or often used in the setting of hypertriglyceridemia. So let's start with mixed omega-3s. Tell me a little bit about the data there. Should I be using those in my hypertriglyceridemic patients?
Well, for your hypertriglyceridemic patients at risk for cardiovascular disease, there are two types of mixed omega-3s, or purified, I should say. There's the purified eicosapentaenoic acid, or EPA, known as icosapentaethyl. I was on the steering committee for the REDUCE trial that did show that in patients that were hypertriglyceridemic and with established disease, or diabetics with risk factors for cardiovascular disease, and triglycerides somewhere between 150 to 499, that icosapentaethyl did make a difference. It did reduce cardiovascular events. So that would be a consideration. The other mix would be a combination of EPA, DHA, and some will use. We'll consider that either the omega-3 acid ethyl esters, and they have not translated. Actually, we really don't have a whole lot of data to support their use in cardiovascular risk reduction. So it's purified EPA, icosapentaethyl, that has demonstrated benefit.
So what about over-the-counter fish oils? I know, they estimate about 20% of Americans use these supplements at some point in their life. And there's a lot of early observational data that made us believe that they were beneficial. But talk to me a little bit about what you advise your patients who come in on fish oil supplements for heart health.
Yeah, so fish oil supplements, theoretically, would have been good, and that's been used for many years. The problem is it's not regulated by the FDA. They're supplements. They're considered part of a diet, and because they're not regulated, you really don't know what your patients are receiving. One of my colleagues, Preston Mason, actually has demonstrated there are a lot of if you will, there are a lot of impurities, and one of those impurities includes saturated fat. So having knowledge that these supplements not only have not been demonstrated to reduce cardiovascular risk, but also contain impurities, I have no confidence really to support their use. And I've taken my patients off of those supplements because of the lack of data.
That's exactly what I do as well, because people come in thinking they're doing good. And in fact, we have data now that tells us that these over-the-counter fish oils can not only raise your LDL, as you suggested, with saturated fat, but they can also increase your risk for atrial fibrillation. And an observational study out of the UK just published in BMJ Medicine showing that they can even increase your risk of stroke if you're otherwise healthy. So I think that's an important take-home message. Do not use fish oils for cardiovascular risk prevention because they're mixed. There's a whole lot of things in there. And secondly, if your patients are on them for risk reduction, think about stopping them because you can get adverse events. So before I let you go, one last question for you. In the modern era of GLP-1 receptor agonists, of course, when we're dealing with our hypertriglyceridemic patients, a lot of them have concurrent obesity or non-alcoholic fatty liver disease, as you mentioned. So why not go upstream? Instead of thinking about the triglycerides and icosapentaethyl, why shouldn't I just treat the obesity, which would help those triglycerides come down? And are you often instead reaching for a GLP-1 receptor agonist before thinking about these cardiovascular risk reduction medicines, especially because the GLPs have now shown cardiovascular risk reduction as well?
Well, or you could use them in combination, right? Because you may get complementary effects. The fact with a purified EPA has been shown not all the patients were obese.
Right.
And so, but they were at cardiovascular risk. And clearly, our diabetics may also be able to not only take GLP-1, but what we don't want to forget is lifestyle. Lifestyle is important, and we don't want to throw the baby out with the bathwater by not including the importance of lifestyle measures. And then, where appropriate, considering GLP-1. We were part of the SELECT study as well, so where we favor them, but we don't want to overuse them either, and just put patients who may not be at risk and may not warrant them just for the sake of weight loss when they may be able to do it more naturally through lifestyle measures.
Well, thank you so much for your insights today. I've certainly learned a lot. When we think about triglycerides, don't think about them like LDL. You want to treat the risk, not the number. Use a fibrate if your trigs are greater than 500 to reduce your risk of pancreatitis. The FDA has issued a warning about statins and fibrates together, so you really shouldn't be using fibrates when you can use a statin instead. And if you're thinking about risk reduction, use a purified icosapentaethyl and try to get those patients off those fish oils. Thank you so much. Thank you so much, Michael, for your insights. And I know I certainly see patients with hypertriglyceridemia every single day in my practice. So I know that I'm going to apply many of this type of knowledge at the bedside. I so appreciate your time today. And thank you all for listening. Until next time.